welcome to our presenters this morning. Welcome to our members. And we're going to continue our study on the National Pharmacare Program. And this morning we have Citizens Reference Panel on Pharmacare. Peter MacLeod is chair and Jean-Pierre St-Onge, member. And we have from the Heart and Stroke Foundation of Canada, Leslie James. Got it right. Senior Manager, Health Policy. And as an individual, Dr. Larry Lin, Professor of Pharmaceutical Science, University of British Columbia. Now, we start with a 10-minute opening, and most presenters find they go over. So if I'm waving at you or anything, you'll know you've hit your 10 minutes, and we'd like you to wind it up. But we'll start with the Citizen Reference Panel. Mr. MacLeod.
Great. Thank you, Mr. Chair, and good morning. I'm delighted for the opportunity to appear before the committee to share with you a very special report, which is in fact being released today. As the committee is well aware, expanding comprehensive prescription drug coverage to all Canadians has long been considered the unfinished business of our Medicare system. Our patchwork approach, with 1 in 5 Canadians having either inadequate coverage or no coverage at all, makes Canada an outlier amongst OECD countries with comparable, comprehensive universal health systems. And while policy experts, clinicians, and pharmacare advocates have for some time encouraged government action, the voice and preferences of Canadians themselves have been difficult to hear. The report I am presenting to you today provides unprecedented guidance from Canadians and is directed to health ministers and policymakers across Canada. I would like, in my remarks, to first review our process and recommendations, and then invite a member of the Citizens Reference Panel, Monsieur Jean-Pierre St-Onge from Dieppe, New Brunswick, to describe his experience as a participant. The Citizens Reference Panel on Pharmacare in Canada, which I chaired, was a substantive effort to provide Canadians with the information and context they would need to reach their own conclusions on the appropriate drug coverage model for Canada. Working under the supervision of an 11-member advisory and oversight committee that includes some of the most respected clinicians and health policy leaders in the country, and with a research grant from the Canadian Institute of Health Research, the Mindset Foundation, the Michael Smith Foundation, and the Universities of Toronto and British Columbia, we set out to convene 36 Canadians, giving them a very special opportunity to help shape health policy in Canada. As with the many reference panels which have helped to influence public policy in Canada, 10,000 letters were randomly distributed by Canada Post to households across the country. Far more than a focus group or a town hall meeting, each letter invited the recipient to volunteer to spend 5 days here in Ottawa. I'm pleased to report that at a time when we routinely underestimate the public's appetite to play an engaged role in public affairs, almost 400 Canadians volunteered, coming from every conceivable corner of the country and walk of life. From amongst the respondents, 36 individuals were randomly selected, with one member regrettably withdrawing due to illness immediately before the start of the process. The members of the reference panel were themselves, as I've said, randomly selected, but in such a way that they mirrored the Canadian population and the prevalence of drug coverage and personal expenditure. I would refer the committee to page 10 of the report to see a map indicating their place of residence, as well as the short biographies we have included. In short, we brought together a cross-section of Canadians, and working out of the Canadian Museum of History with a commanding view of Parliament and that other body of citizen representatives here at the House of Commons, we began our work. From Wednesday until Sunday, the members met and held lengthy bilingual sessions, often running from 9 in the morning until 9 at night. My facilitation team had prepared a detailed curriculum, and during our first days together, we heard from 20 different speakers. These included clinicians, policymakers, pharmaceutical manufacturers, insurers, patient representatives, and economists, and each was intended to add a critical perspective to the discussion. For the members, it was a remarkable immersion in a difficult and nuanced policy field. These 35 people put everything else on hold for 5 days without remuneration in order to serve their fellow Canadians and provide government with their best advice. The question of drug coverage affects each panelist differently, and although they did not agree always with one another, they found a way to tackle these differences with enthusiasm and grace. Working together, the panelists identified 9 issues or areas of concern which they record in their report. Among these concerns, they cite, first, a patchwork approach that leaves millions of Canadians without the coverage they need, leading to poor patient outcomes and increased overall healthcare costs. 2, weak purchasing power, leading to higher than necessary drug costs. 3, inadequate data systems for monitoring the use and cost of prescription medicines. 4, predatory pricing and patent extensions that drive up costs with little transparency on the true research and development costs of new medicines. And 5th, limited public awareness of this issue, leaving many Canadians to cope with inadequate coverage alone. In response to these concerns, the panel issued a series of principles which they believe should guide policymakers as well as a set of detailed recommendations. The panelists named 5 principles: that any action uphold the principle of universality, and that it be patient-centered, accountable to the public, evidence-based, and sustainable. Following extensive deliberations, the panel reached consensus and calls on the government to work with the provinces and territories to implement universal public coverage of medicines listed on a new national formulary. They recommend that this formulary be extensive enough to accommodate the full range of individual patient needs, including rare diseases. They also recommend that all covered drugs undergo a rigorous evaluation process to ensure both the efficacy and value for money of funded treatments. Importantly, and as a first step towards a comprehensive public drug plan, the panel also calls on the government to move immediately to implement public coverage for a short list of basic, frequently prescribed drugs. This short list would begin the shift towards a comprehensive universal pharmacare system and become the basis for this new national formulary. The panel also endorses an ongoing and valuable role for private insurers in providing supplemental coverage. Under any new system, employers, unions, and individuals could continue to purchase private insurance for medications not on the public formulary, as well as other paramedical services. Finally, the panel is not adverse to the government funding the program through modest income and corporate tax increases, which they believe is the most fair approach, and they also urge further consideration of co-payment models, provided they do not create unreasonable barriers for low-income individuals. To conclude, much as the health system is rightly focused on patient-centered care, it's my belief that federal legislation can only benefit from a more citizen-centered approach to policymaking. I hope you will recognize the members of the Citizens Reference Panel on Pharmacare in Canada for their singular contribution to this important debate and the service they have provided on behalf of Canadians. Let me now turn to a member of the panel, Jean-Pierre St-Onge, so that he can comment on his experience.
Thank you. Mr. President, Monsieur le Président, je suis honoré d'être avec vous tous.
I'm honored to be with you today. The letter that I received really attracted my attention on 3 issues: special opportunities, creation assistance, and the cost of prescription medications. I spent my life working in insurance and financial services. I am aware of the gaps in the insurance industry with respect to people who have a pre-existing condition. The vast majority, when they learn that medications are excluded, decide to not proceed. That's the reason why, when I received the call after submitting my request to answer the invitation, I was happy to note that the information I had gathered over my lifetime would serve to some things for the government. When I arrived on October 19th, I thought that all of the information that we had received on those first 2 days that Peter spoke about, while there was so much information, we were just overwhelmed, but we also had the opportunity to ask questions of these individuals. After 2 days, I think that our conscience was awoken, and we got down to work. The team of participants, well, I observed that the participants had the desire to help. When they realized there were problems, you would say that people went into solution-finding mode. Obviously, the group brought a lot of collaboration to the table. We were divided into subgroups, we worked together and discussed together, and finally, at the end, I was very impressed with the process. 50% of the group were men and 50% were women, people of all classes of society, young people, middle-aged people, and elderly people. Diversity and ethnicity, all cultures were represented. People who were new Canadians participated. The diversity was incredible, and I was really impressed. We were guided by a distinguished team. I was very impressed by the entire process. It had really been well thought through. From the basic values upon which we formulated our recommendation, our system needs to be updated. When we repeat the same way of doing things, we'll have the same results. We spent 5 days to identify possible solutions, and obviously the decisions are unavoidable if we want to reach the result. The status quo is no longer an option. Millions of Canadians are affected daily. There are other ways of doing things. We have confidence that our recommendations will help you to reach your objective. Thank you very much.
And now we'll go to Heart and Stroke Foundation, Leslie James. 10 minutes.
Thank you. Mr. Chair, committee members, on behalf of the Heart and Stroke Foundation, I'd like to thank you for the opportunity to appear with you and share our perspectives on the development of a national pharmacare program in Canada. My name is Leslie James, and I'm the Senior Manager of Health Policy with the Heart and Stroke Foundation. First and foremost, I want to express gratitude to Parliament for recognizing the importance of this subject area. Access to medicine remains a vital challenge in the provision of quality health care throughout Canada. The issue of inequitable access to medicines and the need for a national solution has been a key priority of not only the Heart and Stroke Foundation, but also the Health Charities Coalition of Canada, a collaborative group of 30 health organizations that the Heart and Stroke Foundation is proud to work with. Access to medicines impacts every health issue faced in Canada, with some common barriers across all conditions, but also unique challenges faced by individual diseases. We are here today to discuss an issue that represents an ongoing gap in our universal healthcare system. We as Canadians are extremely proud of our world-class system of care and its defining principles that ensure all Canadians are able to access healthcare regardless of ability to pay or geography. We value these principles because they represent fairness and equity, but unfortunately, they don't extend to pharmaceuticals outside of the hospital. Access to medicines remains an area of inequity, fragmentation, and systems failure, with 10% of Canadians being left behind. Without better drug coverage systems, we as Canadians truly do not have universal health coverage. The Heart and Stroke believes there is much opportunity for improvement. We'd like to underscore that the first step for Canada is to continue to strengthen behavior and lifestyle modifications at the population level as a means of both preventing disease and managing heart and brain health. We thank the government, and specifically members of this committee, for their commitment and leadership around disease prevention through healthy living strategies, However, we need more in order to make it easier for Canadians to access healthy food, lead active lives, and remain smoke-free in order to reduce their risk of chronic disease. At the same time, the Foundation recognizes that prescription drugs represent a very important component of treatment for a wide range of cardio and cerebrovascular conditions. When prescription drugs are used appropriately, they help to prevent disease, save lives, and improve quality of life. They can shorten time spent in hospitals, reduce demand for physician services, leading to decreased costs for the healthcare system in the long term. While innovation in pharmaceuticals has led to medical breakthroughs and improved health status for many Canadians, our reliance on medicines has become greater, and many fear the rising costs will be unsustainable for our system. Prescription drugs have risen from 6.3% in 1975 to 13.4% in 2014 of overall healthcare spending in Canada. Our reliance on prescription drugs is clear and not forecasted to diminish. Roughly half of Canadian adults take at least one prescription medication, while 15% take 4 or more. This means that in this room, at least 5 of you are taking one medication daily. And 90% of Canadians with chronic diseases take at least one prescription drug, and 54% of Canadians with chronic conditions take 4 or more. In 2014, Canadian pharmacies dispensed roughly 87,000 prescriptions for medications to treat cardiovascular disease. That's up 2.5% over the previous year and represents the highest dispensed category of medications in Canada. Prescription drugs, especially taken over an extended period of time, can be very expensive. And overall, while a majority of Canadians have some level of drug coverage, access to medicines is neither universal nor equal. In some cases, people go without recommended medications because they cannot afford them. In other cases, purchasing the required medications puts them in serious financial difficulty. Next time you pick up a prescription medication from the pharmacy, take note of the initial cost and the cost after insurance benefits have been applied. You'll likely be very surprised by this difference. Between 60 and 75% of Canadians are covered by private insurance plans, and between 9 and 43% qualify for government insurance depending on their area of residence. But unfortunately, 3.4 million Canadians are either underinsured or not insured at all for out-of-hospital prescription drugs. In a survey of Canadians with comorbidities, heart disease being one, 14% report having no insurance for necessary medications. And access is a major issue, with more than 1 in 5 Canadians reporting difficulty paying for prescription medications without insurance coverage, and 1 in 10 reporting difficulty even with insurance coverage. In 2010, 12% of Canadians reported paying more than $1,000 out of pocket for medical costs, and 10% said they did not fill the prescription or skip doses as a result of the cost of their medication. Both of these figures depict Canada as much worse off than comparator countries. Non-adherence to prescription drugs is extremely problematic and has been associated with significant increases in mortality, hospitalizations, and healthcare costs. These issues need to be addressed in order to ensure sustainability of our healthcare system. So why are 10% of Canadians underinsured or not insured? Many do not have insurance because they are self-employed or working on contract or part-time work. And 1/3 of Canadians employed full-time and 3/4 of part-time employees have no insurance for prescription medications. In addition, many drug plans provided by employers have maximum coverage thresholds and a limited range of therapeutic options. So even when they are covered by private insurance, sometimes they find the options unavailable to them that they need to meet their needs. And with the number of Canadians working part-time increasing, and many employers reducing drug coverage from insurance plans, fewer Canadians are covered for the necessary medications through their jobs. We need to do better for these underserved Canadians who are forced by circumstances to choose between putting food on the table and taking their medications. The Canadian drug system does not provide equitable coverage between geographic regions. Drugs availability differs between provinces because the country lacks a common formulary. Coverage of necessary, cost-effective essential medicines needs to be universal without geographic barriers. Finally, we need to address the cost of medicines in Canada. While there has been some great cost savings as a result of patent expirations and shift towards generic use, research shows that generic drugs in Canada are more expensive than foreign markets, with only Switzerland outpricing Canada. Recognizing the importance of drug access, the World Health Organization has declared that all countries are obliged to ensure equitable access to necessary medicines through universal health coverage. Canada is uniquely the only developed country with a universal health care system that does not cover prescription drugs. In 2012, the United Nations unanimously endorsed a resolution advising governments to ensure universal health access to quality health care without financial hardship. Yet Canadians continue to experience such financial hardship around access to medicines. It's time for Canada to fill a gap in our healthcare system and truly provide universal health care for all. The Heart and Stroke Foundation believes in the values of universality, equity, equality in our healthcare system. All people living in Canada should have equitable and timely access to necessary prescription medications based on the best possible health outcomes rather than their ability to pay. The solution needs to be made in Canada, addressing our specific context and needs, while learning from the success of pharmacare programs elsewhere in the world. Building a national pharmacare plan will ultimately improve drug adherence, reduce the burden of health system, and create a healthier, more productive population. We call on the Government of Canada to take a leadership role in addressing the aforementioned issues, and we have a number of recommendations that can help move this forward. In particular, we recommend that the Government of Canada create an advisory panel that would inform the development of comprehensive, evidence-based pan-Canadian pharmacare standards, which include universal and equitable access to essential medicines. Federal, provincial, and territorial governments come together for collective negotiations to reduce the cost to healthcare system and increase access to needed medications. The Government of Canada take a leadership role and share the cost of implementing pharmacare standards with the provinces, and the health charities and the Canadians that they represent be invited to participate in federal, provincial, and territorial consultations to support the development of pharmacare standards that meet the needs of all Canadians. In conclusion, we are confident that in working together across sectors and levels of government, with the inclusion of the patient voice, we can create a drug system for Canada that is truly universal, equitable, and leaves no Canadian behind. The Heart and Stroke Foundation will continue to advocate for progress on this issue, and we are ready and willing and able to work with the federal government and other health charities to ensure that all Canadians of all backgrounds have access to affordable and necessary prescription drugs. I thank you for your time today.
Thank you. You had 9 seconds left. Dr. Lin, please. 10 minutes.
Good morning, Mr. Chair. Thank you very much for the invitation to speak with you today. Just by way of disclosure, I'm the principal investigator on a CAHR team grant evaluating policy and reimbursement decisions around rare disease, and I'm also a member of the BC Ministry of Health Advisory Committee for Expensive Drugs for Rare Diseases. So I'm going to talk to you today on my perspective and my experience specifically around orphan drugs and rare diseases. In my discussions with provincial payers, particularly in BC, as that's where my experience is, they have raised 4 key concerns, key areas of concern, particularly around evidence, price, access, and communication and transparency of decisions in general, but specifically as they relate to reimbursement decisions for drugs for rare diseases. We are in the midst of a paradigm shift and really a disruption in drug development, where we're moving from the blockbuster model and biologics to more niche products, targeted products around orphan drugs and rare diseases. This disruption has resulted in an exorbitant cost of many of these drugs for rare diseases, where we've been talking of $1 million per year per patient, which is lifelong for treatment. And now with others in the pipeline, we're seeing prices on the order of potentially $2 to $3 million. And the cost just seems to be continually pushed higher. With new technology and incentives, the number of drugs in the pipeline with potential orphan indications continues to increase, which is a good thing, offering new treatments for our patients, but will obviously bring further pressures on our system. Given the costs, it's obviously not feasible for any Canadian to be expected to pay out of pocket for these drugs if they are not insured benefits. Therefore, I think we also need a bold paradigm shift or disruption in our policy and reimbursement decision-making. Now, in Canada, we know we've got the Common Drug Review and more recently the Pan-Canadian Pharmaceutical Alliance. The Common Drug Review was implemented with the specific objective of providing evidence of value, efficiency, and consistency of evidence evaluation across the provinces. The Pan-Canadian Pharmaceutical Alliance was initiated with the objective of having a strategy for collective negotiation on drug prices following by the provinces following CDR review. The theory is that this would result in greater cross-country equity. However, such is not always the case. Even in cases where pricing and product listing agreements haven't been reached with pharmaceutical manufacturers by the PCPA, some provinces have chosen to fund some drugs, resulting in inequity of access. In a recent study of 2,600 Canadians, we asked Canadians what they felt were the most important considerations related to funding of new drug therapies. The top 5 considerations were the effect of the drug on quality and length of life, the safety of the drug, the ability of the drug to really work, and the severity of the disease that it's meant to treat. Those were the top 5 related specifically to the drug and the disease. The next most important factor, however, was equity of access, both for minority populations, and in a more recent study, we also found equity across provinces was also very important. So despite the Common Drug Review and the PCPA, we know Canadians do not have equal access to all treatments. However, for common diseases or even cancers, there are generally alternative therapies, such that most patients are not necessarily left completely untreated, notwithstanding some of the comments we just heard this morning about the ability to pay and about the ability to get coverage. This is specifically speaking about equity. However, for many rare diseases, there is generally only one therapy. Thus, with different coverage decisions across provinces, there is truly differential access to treatment. And I'm not suggesting that all treatment should be available to all patients across all provinces, whether it be for a rare disease or a common disease, but that the development of a national pharmacare program would prevent this from happening, and all patients in Canada would either get access or no patients would get access based on a transparent, consistent, evidence-based decision-making process. Thus, evidence-based equity of access across all provinces. We already have evidence of such a program having worked for a rare disease, specifically Fabry's disease, and specifically the Canadian Fabry's Disease Initiative, or CFDI. This initiative was conceived due to the inability of Nova Scotia to pay, given the high prevalence of Fabry's disease in that province. This is an initiative that, as I understand it, was initially funded as a partnership between provinces, the federal government, and the pharmaceutical industry, with 2 primary components: drug procurement for the entire country, and data evaluation, collection, and the development of a patient registry. As a result, we have an example of equal access. Only eligible patients receiving treatment based on guideline-based care and excellent data on the treatment effects and the natural history of Fabry's disease, which contributes significantly to reducing the trepidation and uncertainty around treatment coverage decisions. This initiative, I believe, could act as a model for other rare diseases as part of a national pharmaceutical strategy, given that this model provides a data collection platform to inform research, evaluation, and decision-making. It supports evidence-based decision-making. It supported procurement and pricing negotiations. And also, in this environment, I think it could provide an opportunity for notice of compliance with conditions or reimbursement with evidence development, which we know lots of people are talking about, but which we really haven't seen implemented in any situation yet. This also speaks to what is included in the proposed Canadian Orphan Drug Framework, specifically a post-marketing authorization plan, which I feel is imperative given the limited evidence on the efficacy of these drugs when being reviewed for market authorization. Although I've been skeptical about how this could occur in the current regulatory and reimbursement environment, given the separation between federal and provincial responsibilities, a national strategy with an active post-marketing authorization pharmacovigilance plan would provide a framework that would support the growth of the evidence base. Economies of scale of a single system could be implemented across multiple rare diseases, resulting in system efficiencies, and provide a framework or a platform for international collaboration, and of course, provide a national platform for price negotiation. So, in closing, a national strategy for reimbursement that could be the start of a national pharmacare strategy would support equity of access or non-access depending upon the evidence, system efficiencies on multiple levels, potential earlier access to therapy for patients given in an environment to support notice of compliance with conditions or reimbursement with evidence generation. It would support evidence-based, consistent reimbursement policy and decision-making, spending only where spending is warranted, and improved transparency and communication around systems and reimbursement decisions. I would like to thank you once again for inviting me, and I hope I provided you with some insightful comments for your deliberations.
Thank you very much to all the presenters, and I'm sure we have a lot of questions for you. We're going to start our first round of questions. There are 7 minutes, and we're going to start with Mr. Erskine Smith.
Thanks very much. I've only got a couple questions, then I'll split my time with Doug. My first question is, as we hopefully move towards a universal pharmacare plan, we talk about improved access to drugs, but also we can actually save in drug expenditures. It seems, if we can hit both of those goals, it seems like a good idea to me, but we're not going to get there tomorrow. So in your view, can you lay out the first steps that a government ought to take in moving forward with establishing a national pharmacare plan? So I've read a lot about national formularies, for example. Can you lay out one or two key first steps for a government to take to move forward with this initiative?
Sure, I'll start. And I think, this is the area that I'm most familiar with, and I think, and I propose this as, for want of a better term, an area of low-hanging fruit, where we have a model which wasn't perfect in the CFDI. I think that does provide us a really good starting point for a model to build specifically around orphan drugs for rare diseases, and specifically maybe start to target those groups who are most at risk and who have the highest impact, and then continue to incrementally build from there. And I think there are some other good recommendations in other reports as well to go more global about starting with a smaller common formulary. I think we're all cognizant of the difficulties it would be in going large initially. I think this is what I would perceive as being kind of some initial, maybe early, quick wins to see if it might work.
And any other comments?
I may quickly, it was certainly a matter of concern for the panel. Frequently, members would ask, well, what's the timeline for potential reforms here? How long might it take? And they would urge the government to act as quickly as possible, and that's really the rationale for their immediate action or urgent first step concerning the smaller basic list of medicines. I think that would be a significant down payment towards a comprehensive system.
I think it needs to be a phased approach. We're not going to solve this, in a short time frame, but really creating a vision with defining principles that we're striving to work towards is important. The consultation piece is very important too, so getting the patient voice and learning what Canadians want, because our context is very different. We also need to learn from other countries that have gone this route and figure out what might work in Canada and what might not. But I see this being a short, medium, and long-term approach, and ultimately getting towards those defining principles that we've all commonly addressed.
My second question is, so you read about the billions of dollars that can be saved on the consumer side if such a program were implemented, and it's unclear to me exactly how much this would cost the government up front. If there's savings on the consumer side that overwhelm the upfront cost on the government side. So one study out of UBC said you could save up to $8 billion, I think, or somewhere on the consumer side. When other countries have gone down this road, or when we look at Canada going down this road, to ensure that we don't have red on our balance sheet for a long time, given the upfront savings for consumers, is there a way that other countries have gone down this road to actually capture some of those consumer savings and share the savings between government and the consumer side and make sure we stay in the black, but overall there are savings?
I do not know the answer to that, and to know what other countries have done. And I know there's evidence on both sides, where we know Steve's paper says there'll be $8 million in savings, and we've seen other evidence saying maybe not quite so much. So sure. I know there's a debate about what truly will those savings be, and I absolutely appreciate the the implementation costs and development, and that's why I think this incremental development and implementation is going to be really key, because I don't know that there's an answer in terms of the absolute savings and the outcomes.
I don't know if any other comments just about how government can perhaps share in some of the savings at the end of the day.
Well, I might just add briefly that, of course, as the committee appreciates, there is ultimately only one payer, and I think it was most persuasive to the panel that a public approach would mean greater economic efficiency in our ability to purchase and provide these medicines.
Doug, over to you.
All right. Thank you. Well, thank you thank you all for coming. Now, my first question, Mr. St. Onge, you spoke about, you were talking about, a lot of private drug plans, and you made a mention of pre-existing conditions. Are you aware of the prevalence of people on employee-sponsored drug plans being denied coverage due to pre-existing conditions?
That's the beauty of a group. They don't select, but individual. My statement was individual people that want the group, they cover everyone. Does that answer your question?
I was thinking more if you knew about, as in trends, like in your discussions, in your, maybe Mr. McLeod, you might know some of the answer to this. Was there discussion about that among the group of people being...
No, that was my background that I was bringing to the table. I thought that, that awareness would raise the consciousness.
Okay, all right. Okay.
I think for members of the panel, the greater concern, as reported to them by members of the insurance industry, was the consequences, especially with small businesses that have small group plans, and one employee then develops a rare disease. And very quickly, the cost of providing those medicines swamp that business's ability to sustain that private insurance. And that is definitely a major concern, and I think it's one echoed widely across the small business community and amongst insurers.
Okay, thank you. Now, Ms. James, you talked about, particularly with cardiovascular medications, that there is, cost due to non-compliance. People's morbidity and mortality is higher when they're not taking their meds. Are you aware through the Canadian Heart and Stroke Foundation of any overall societal costs, like costs to the medical system, how much a year it is costing our system for people who are not taking their medications?
I don't know exactly that figure, but there have been studies in Canada and elsewhere in the world showing that non-adherence and issues with cost quite often lead to non-adherence, which then increases the risk for patients presenting with heart attacks in emergency departments. So we are seeing that in the long term, the cost of treating cardiovascular disease in the healthcare system is more costly than it would be to get them on, prehypertensive medication or whatever it needs to be in the long term.
All right, thank you.
Time's up. Yep. Okay, Ms. Arter.
All right, thank you very much. My first question goes to Mr. McLeod. Mr. McLeod, you said that this group of individuals that sat on this panel was randomly selected. Now, they seem to be a pretty knowledgeable group if they were able to come up with these recommendations. Can you please explain to me how the random selection was done?
Absolutely. It's a process called a civic lottery, and it's been used to select members for almost 30 panels across the country at the municipal, regional, and national level. More than 1,000 Canadians at this point have been selected, and 1 in 60 households in Canada have received similar invitations to participate, serving on panels examining health issues like supervised injection sites, but also municipal planning issues concerning mass transit. From amongst in this case, I believe 378 volunteers, they're then entered into a database, and it's done in such a way that effectively we're blind to the outcomes of it. We know what the demographics of the Canadian population is, and so effectively a computer algorithm sorts through all of those applicants and then randomly selects a series of attributes: the gender, the age, the geography, and in this case we are also looking for what their annual out-of-pocket expenditure is on medicines, and we are also looking at whether or not they have drug coverage. From that composite of attributes, we would then blindly identify a series of candidates who fit that profile, and from amongst those candidates, again, blindly, one name would be selected, and then they would be contacted and invited to serve.
Okay, thank you. Now, in order to come up with the recommendations here, I've been studying pharmacare on this committee where, well, we've been here for quite some time now. The terminology used within this report, I would say, is at about my level, and I'm about 6 to 8 months into this study. Now, these folks were only together for 5 days. So tell me a little bit about how their discussion was driven. Were they presented with all sides of the argument? Were they presented with what it might look like to advance our private healthcare system as well as continue forward with the public healthcare system? Or was just one side of the coin presented to them?
Certainly that was a concern for the conveners of this process. That's why we had an 11-member advisory committee. Their names are contained in the appendix of the report, and we had lengthy discussions about how we could, to the best of our ability, create a balanced curriculum so that amongst those 20 invited guest speakers, there would be a range of perspectives provided. I'll leave it to my colleague, a member of the panel, to explain his sense of the fairness and balance of the process. But I would also suggest that, given 5 full days where you're really in the thick of it with people, with the benefit of all of these materials in front of you, and frankly, I think we underestimate the capacity of the public to play a more sophisticated and informed role in policymaking. It's important to note that the report is really in 2 halves. The white pages, we wrote. The blue pages were exclusively the words of the members of the panel.
Thank you. So my next question then is going to the Heart and Stroke Foundation, Ms. James. Now, you described the fact that prescription drug use, of course, has increased quite drastically over the years in Canada. Can you comment as to why we're seeing that increase in prescription drug use?
Sorry, can you repeat that?
Can you please tell us why we're seeing an increase in prescription drug use in Canada?
I think prescription drug use is increasing throughout the world. It's not unique to Canada. It's increasing in cost, and it's an increasing proportion of our healthcare spending, and that's the concern for the Heart and Stroke Foundation.
Thank you, but why?
I can't speak to that. I think that's a clinical question.
Okay. And in your estimation, you said that there is a number of other countries that you've looked at that are doing a national pharmacare program. Which country is doing it the best?
I don't want to say which is doing it the best and which is doing it the worst. I think what would work for Canada is looking at our needs and our context, and considering the fact that we do have private insurance already. I think the UK has an interesting model where there's a coverage of prescription medication available to all people, as well as private insurance available as a top-up. Perhaps that's worth looking into in Canada, because it's a quite similar context.
Okay. In your estimation, then, should we also protect private insurers as well as public?
I think there needs to be a balance in Canada, and given that we've had this system in place for so long, there needs to kind of be a consultation to see what would work best going forward.
Okay. You say the UK, I mean, your reason for drawing attention to the UK is the fact that they've preserved their private system in addition, or as a top-up, are the words you used, to the public system. Mm-hmm. So you're saying that that's a positive thing then, is what I'm hearing you say?
I'm speaking as an individual. I study part-time in the UK, and I think it's quite wonderful that you access all medications without major service charges to individuals. And there is option to top up with private insurance through employers.
Okay. Do you see any disadvantages to the UK system?
Not that I'm aware of, no.
Okay. Mr. Lind, I would be interested in asking you the same question. If you were to look at the international context, other countries that have a universal pharmaceutical system, what would your observations be? What country is doing it well? What should we learn from?
I'm going to speak from the orphan drug environment because that's where I've worked the most, and we've actually had a study done out of Ottawa that's actually looked at orphan drug, rare disease drug decision making internationally. And what's interesting is lots of countries have processes, but we haven't been able to, or at least have frameworks in place to support decision making, much as we have in British Columbia.
I'm sorry, Mr. Lynn,
Yes.
we are short on time. We have about 20 seconds. Could you draw on a specific country, please?
No, I cannot. I'm afraid
Okay,
nobody
thank
has a
you.
really good process in place.
Okay, thank you.
Okay, Mr. Davies.
Thank you, Mr. Chair. Thank you to all the witnesses for being here today. Mr. McLeod, I want to quote from the preamble to your report. The report writes, "There is an urgency behind our recommendations and action needs to be taken immediately. People are suffering and dying as our current system does not meet their needs. Our population is aging and new needs are emerging. We have to look out for all Canadians, young and old, regardless of socioeconomic status. We, as a panel, expect our federal, provincial, and territorial political representatives to listen to and review our advice." My first question is, given that we have 3 years left in the current federal government's mandate with the next election in 2019, it being 2016, would you recommend that this federal government act this Parliament on the recommendations?
I certainly believe it was the intent of the members of the panel to signal to government that they expected action within this term of Parliament.
Thank you. So I'm going to move to the first step that is recommended by the panel. The panel calls on the government to move immediately to implement public coverage for a short list of basic, frequently prescribed drugs as a first step. I think you called it a down payment on the national comprehensive formulary that ultimately you recommend. Can you expand a little bit on that for this committee? How many drugs sort of are you contemplating, and what kind of drugs do you think this government can act on immediately to provide coverage for Canadians on a national basis now?
This is an evolving concept, the idea of a basic list. But typically we're talking about between 100 and 200 medications that, to the best of my understanding, make up about 40 to 50% of prescriptions. These drugs are often used to treat chronic illness, and often they prove quite costly to those people without insurance. And so those who are in precarious employment, those who lack coverage, are low income, perhaps stand to benefit the most by a basic list. And of course, it would also begin to normalize the idea of public insurance for all Canadians. In a sense, it's your biggest bang for the buck in terms of health equity and health outcomes.
Can you give us a couple of examples of what kind of prescription medication you're talking about there?
I have to be careful that obviously I'm not a physician nor a pharmacist, but these would be to treat normal chronic conditions that might include hypertension, that might include gastrointestinal issues. It's commonplace medicines that physicians and certainly patients would be very familiar with.
And to be clear, I'm the only prescription I'm asking for here is a policy one.
Thank you.
So, my third question is, your panel recommended ultimately broadening the system to a universal public coverage of medicines listed on a new national formulary. You recommended that this formulary be extensive enough to accommodate the full range of individual patient needs, including rare diseases. I also note in the panel that the principles that were identified by the panel either are the same principles or mirror or are compatible with the principles under the Canada Health Act. So I'm curious about your views on whether the panel would like to see the creation of a national public insurance system as a standalone system with a national formulary administered on its own, or whether it sees an expansion of insured services under the Canada Health Act under the present system of delivery, or is there any big difference between the two?
I'm not sure if there's a significant difference between the two. I know it was the intention of the panel to see that any new regime would be operated at some arm's length from political pressures so that it could be a really evidence-based system that was directly accountable to Canadians as both patients and as taxpayers. I think it's important, however, that any new public insurance plan does reflect the intent and spirit of the Canada Health Act. And I think to members of the panel, they were surprised to see that our existing patchwork approach really is not consistent with those principles. Perhaps besides universality, the key concern was the degree of variability that exists across the country. Mm-hmm. And that's why in working with the provinces and the territories, they call for national federal action.
Mm-hmm. Now, Mr. McLeod, I've already used language or quoted language from your report that uses some pretty tough language. People are suffering and dying under the current system. Ms. James, I'm going to turn to you with Heart and Stroke. Is it your organization's experience that under the current patchwork system where people are not necessarily covered, are people dying in Canada because of their inability to access prescription drugs?
Well, I did mention examples of people unable to access necessary and basic prescriptions for cardiovascular disease who skip doses or non-adherent, and that results in increased rates of heart attack presentation in emergency rooms. We've been able to reduce the risk of mortality associated with heart attacks, but many people don't make it, unfortunately, and that could be prevented with better access for all Canadians to preventative prescription medications.
And is morbidity a consequence of this gap?
Yes, morbidity and mortality both.
Thank you. Back to you, Mr. McLeod. Researchers estimate that, before this committee and otherwise, that overall savings in Canada could be achieved by a national universal pharmacare program in the nature of $4 billion to $11 billion annually, depending on the structure of the system and the parameters adopted. According to your report, an expert panel, I think, urged a more conservative view of cost savings achieved through universal pharmacare. Was the reference panel still in favor of a national universal pharmacare program if it achieves universal coverage but results in no overall cost savings for pharmaceuticals to government? Should we proceed anyway?
I want to be careful in not speaking beyond the text of their report, but my understanding of their intentions was that improving health outcomes and addressing the fiscal inequities for Canadians probably superseded other concerns.
Time's up.
Thank you, Mr. Chair.
Mr. Cohn.
Thank you, Mr. Chair. I want to thank the panel members for appearing before the committee today. And my first question is to Mr. McLeod. Your recommendation that this national pharmacare should be provided through public insurance. So this will ensure all Canadians have the same access to pharmaceutical coverage. It's going to unify the buying power and the public insurance system should be accountable to Canadians through arm's length agency from any profit motive. And in the next paragraph, you will say this system must also allow the individuals and employers to continue to purchase optional private drug insurance. So when we have the national pharmacare, it's going to cover all Canadians, and what kind of role you think, why do we need any private drug insurance? It's going to leave a door open, for competition with the national pharmacare. And don't you think it will be a threat to the national pharmacare? What kind of role you see for the private insurance still in there?
Thank you. It's an excellent question. It was not the intent of the reference panel to see that all available drugs would be covered through a national formulary. Those that were evidence-based and judged to offer the best course of treatment at a reasonable price are those that would be listed as they are in other countries with national formularies. Nevertheless, it was important to members of the reference panel to preserve an avenue through which patients could still exercise some choice in the medicines that they access, and they see the private insurance market as the opportunity for supplemental coverage to provide access to those additional drugs.
So my question is, like, here we're trying to, bring in national pharmacare. So, you said 1 in 5 Canadians, they probably don't have the insurance or they don't have enough. So if we still want to, that will be kind of like two-tier system. So, how about the people who cannot afford to get the private insurance, and how would we cover them?
I don't think that the two concepts are in any way mutually exclusive, and we can look to many other countries that have robust systems of publicly funded prescription medicines, but that also have supplemental drug insurance. Much as we do, still with a robust Medicare system in this country, many individuals, either individually or through their employers, hold private insurance, which of course gives them access to paramedical services.
Okay, well, I'm not really satisfied with the answer because, we got people who are probably on a fixed income, and if they were to get the private insurance, they can't probably afford it. They're having difficult time to put their bread and butter on the table as is. So, my concern is leaving the door open, for not coverage for those people who are disadvantaged.
It's important to be clear that we're not talking about preferential access, nor are we talking about any barrier to required or necessary medicines for those on public insurance. What we're talking about, perhaps, one example is the difference between a generic and a national brand medicine. And some people may continue to prefer that recognized brand, but as most clinicians are aware, those medicines are effectively identical.
Okay, that was my next question was on generics too. So you start on that. Is there any study like how much money is being saved by generic drugs compared to brand name drugs? You have some numbers there? Or?
I would refer you to the Generic Manufacturers Industry Association, which I know has extensive studies that can answer your question more conclusively.
Okay, thank you. Do I have more?
2 minutes.
Okay, thank you. So thanks, Mr. McCont. My next question is to Dr. Lien. During her appearance before the committee, an official from the PMPRB highlighted several challenges facing the organization, including controlling the price of high-cost specialty drugs such as biologics, oncology drugs, and orphan drugs. In her testimony, the PMPRB official identified the need for the PMPRB's legal regulatory framework to adapt to these changing circumstances, and if it is to remain relevant and effective in protecting consumers from excessive pricing. So in your view, how does the PMPRB need to evolve in order to better control the price of high-cost, especially drugs such as biologics, oncology drugs, and orphan drugs?
Again, that's a question around international pricing control, which isn't my area of expertise. I think looking at what's happening with the PMPRB and the challenges that they're having in court now, looking at the ways that they are trying to control prices and they are having challenges with that, I think that just speaks to my proposal of a disruption in our reimbursement and pricing process here in Canada, and what the actual answer to that is, I don't have that answer.
Okay. So should a national pharmacare program be developed? Do you see an ongoing need for the PMPRB? Why or why not?
Yes, I do, because I think we need to control the prices. I think if we look at where the prices are going with pharmaceuticals, particularly given the paradigm shift in drug development, we're looking at more development of personalized and precision medicines with drugs that are going to be orphan priced. That's just going to increase the need for price control, with what I foresee as prices continuing to be pushed to the limit.
Okay, so do you think the buying power, if when we have the national pharmacare, the buying power will have some effect on getting the drugs cheaper probably with the help of PMPRB, or I wonder what kind of role.
That would be my opinion, yes. And that's exactly the premise that the Pan-Canadian Pharmaceutical Alliance was developed under, was to have a consortium to increase buying power. So that would be my understanding and my belief.
So with
Time's
the,
up.
thank you.
Now your time's up.
Thank you, sir.
You're welcome. Okay, that completes our 7-minute rounds. We're going to go to 5-minute rounds now. We're going to start with Dr. Carey.
Thank you very much, Mr. Chair, and thank the witnesses for being here today. We've had a lot of witnesses that are really putting forth one type of model, like a monopolistic type of model moving forward in Canada. And I've had some challenges with the study that we're doing because I don't see a lot of contrarian views. But I see you guys have brought up a few interesting points I'd like to investigate a little bit further. Maybe my first question to Dr. Lind, my colleague asked if there's a system out there that is an example that we could look towards, and in Canada we're trying to define who are the Canadians that are really having problems with it. If you look across the world, the UK has really put in a system where they're looking more of a monopoly, but if you look at the results, there's certain restrictions on certain medications that are available in other parts of Europe, and the UK has a worse cancer survival rate of these other countries. New Zealand has a monopolistic system, and you actually see people from New Zealand moving to Australia just so that they could get the drugs that they need. And you mentioned that if we do put in a system like that, it really is going to affect choice. And in other words, everybody gets it or no one gets it. So me as a Canadian, if I pay into a system for years and it comes to a point where I need medication, you're the expert here on rare diseases, would you say that's even fair if some bureaucrat is going to be making a decision that I can't get these drugs covered under a system that I paid into my whole life?
And I guess my point is that I'm not arguing that every drug should be covered.
I know
and so if I'm saying everybody doesn't have access, I'm merely suggesting that the evidence doesn't suggest that the drug has a significant enough impact on quality or quantity of life, or that the cost is such that it doesn't warrant reimbursement, that then that decision that is being made, and not necessarily by a bureaucrat, I think we have multiple contributors to that decision-making process. That means everybody has the same access, whether it be access to the drug or maybe not access to a drug that we shouldn't have access to.
So so if somebody's advocating for a monopolistic system, and like I say, to look at the fairness issue, all Canadians will be asked to pay for it. Should Canadians be able to buy private insurance then? In other words, if there are these drugs that are unique, somebody who's advocating for a monopolistic system, if they're trying to really help out all Canadians, and there's a portion of Canadians that can't get certain drugs, well, aren't we just transferring one system that's not covering people to another system that may not be covering people if we don't allow access to private insurance?
And I'm not arguing for no access to private insurance, but I also think we can look at the private insurance industry, and I think there's a paradigm shift going on there too, whereas historically they've covered everything, and that's changing. We've seen it in the news in the last 4 weeks, where they've been discontinuing coverage on biologics because of the pressure from the employers. So I think, both systems work together, and they're looking at their reimbursement policies and procedures at the same time.
I think and that's something we have to look at as well. Again, I like the contrarian viewpoint. I think, Ms. James, you're one of the few witnesses we've had here. You talked about heart and stroke and, the emphasis that you guys actually have on behavior and lifestyle interventions, I think you said, and healthy living strategies. And what I find problematic, and I think one of the contrarian viewpoints in one of your appendices, Mr. McLeod, one of the persons said, we should be having this as provide a health benefit, not necessarily a drug benefit. And I was wondering, Ms. James, in a national pharmacare program, we would cover statins for life, we'd cover blood thinners, we'd cover blood pressure medications. Have you ever done a study, your organization, where if you can actually get people to take preventative measures, exercise, diet, how much of a cost saving that would be? Because if we're looking at trying to get together for healthier Canadians, I think we should take a more holistic viewpoint at it. My background, I'm a chiropractor. I actually think you should look at natural interventions first before people get into drugs. But if we have a system in place like this, it's the easy thing to do to take a drug. Now, have you or your organization ever done a study on cost effectiveness on not going the drug route and saying let's pay for interventions that may change lifestyle, change a person's weight? Have you ever done something like that?
It's a fantastic question, and we have done studies of that nature. We know that 80% of heart disease and stroke is preventable through lifestyle modification, so changing your physical activity levels, remaining smoke-free, and most importantly, changing your nutrition. So we need to make sure that access to healthy food and fresh and whole unprocessed food is affordable for all Canadians. And that's a major challenge that we're facing right now. That said, there is a role for pharmaceuticals in preventing and treating cardio and cerebrovascular disease, but much of this is within control personally, but we need a system in place that makes it easier for Canadians to make a healthy choice.
You're done.
I'm done?
Yep. Mr. Oliver.
Thank you very much. So I just wanted to begin by thanking the Citizens Panel for the work that you've done. I mean, to come out of your homes and take on this study as volunteers, I think is a wonderful accomplishment, and the time and energy you put into it is quite remarkable. So thank you very much for that. On this committee, we've been talking about this topic for some time now, and I've been sort of going to how do we keep this as simple as we can. So to me, the basic transaction is a Canadian meets with a caregiver, doctor, nurse practitioner, a prescription is written, they go into a pharmacy, and they receive the drug. There may be a small flat dispensing fee, maybe a co-payment yet to be determined, but they receive the drug, they go home, they take it. Presto, 25% of Canadians get what the other 75% have, access to drugs. And for the pharmacist, there's a win, because the pharmacist, instead of dealing with hundreds of private insurance plans, has one organization they contact for reimbursement and for their fee. So the first complexity, though, is what would be permitted in that. What prescriptions can they go in with? I heard slightly differing views here from Larry and Peter. The World Health Organization has already come out with a list of essential drugs. I think you've recommended that the essential drugs are there. This is pretty simple. I mean, it's the Pareto principle. 80% of prescriptions are going to be coming from about 20% of the available drug pool. Most of those are already in generics. Most of them are already under pretty aggressive pricing models. That should be a simple list to start with. And then we add in the other rare disease drugs and the other ones as we go forward with it and think about how to compensate it. So the first one is the establishment of that essential drug list. CADTH has said they think they could manage that. Did you have any thoughts on a new agency or letting CADTH take on that, or Leslie or Peter, either of you?
It's a great point, and I think the World Health Organization has that list of essential medicines that they recommend for a reason. They're cost effective, they will likely improve population health in the long term, and that's a first stepping stone for us as Canadians, so I'm quite pleased that you brought that up. I think whatever system we move forward with needs to be transparent, it needs to consider public administration and cost savings to Canadians. I can't speak to whether CADTH is the right agency for that, but again, there are options to look elsewhere in the world. You know, the UK has NICE. Other countries have different regulatory bodies that do that. So perhaps we have that in place in Canada already. Perhaps we need something different.
We didn't look at the exact agency, but again, I think the panel did endorse the idea of there being a kind of arm's length relationship. They really want this to be an evidence-based exercise, and they do want to preserve a role for citizens.
Exactly. So it has to be evidence-based.
Well.
There has to be clinical preventative. So, and just for Canadians who might be watching our committee, this is already in place. If you're going into a private lab, or if you have your doctor's asked you to get a lab test done, or going into a private diagnostic, there's already mechanisms in place in every province for that lab or that diagnostic center to build the province. You don't pay as a Canadian when you go in for those services. So we're broadening that out to include pharmacies, but the structures and the billing processes are already in place in every ministry, and some of those labs, some of those tests are not insured, and then you pay yourself, but most are, and there is that choice then that the consumer has between do I pay for something a bit different, or do I stay in the publicly funded plan? So the second question then is how do we pay? And after we've decided what drugs are in that formulary, and I saw you come up with some suggestions around potential income tax changes, corporate taxes. 40 to 50% of Canadians right now are insured through private plans through their employer. Would it make sense to you that those costs then would be recovered through some kind of corporate tax, so it doesn't cost the employer anymore, but we can use that funds to publicly administrate the plan?
You've got it exactly.
Okay. And then on the specialty or the sort of drugs, the rare disease drugs, is there a panel capacity that's in place that would somehow, I can see these are very complex, there's lots of diversity. We've heard from tons and tons of rare disease groups about their concerns about access to new and emerging treatments, and how do we quickly adopt those and bring them into a restricted formulary? Any advice on who should be doing that?
Well, we do have experience. We do it in British Columbia, we do it in Ontario, and other countries are doing that, where we know we evaluate them differently. So specific panels with specific expertise to evaluate orphan drugs have been developed, so that's certainly doable.
Time's up.
Thank you very much, and thank you again for your...
Mr. Weber, 5 minutes.
Thank you, Mr. Chair. I want to focus my questions to the citizens panel members that are here. I read through this and found it quite interesting. I read the people who are on the panel and their backgrounds and such, and of course your recommendations to have a universal mandatory public drug insurance system that provides necessary coverage to all Canadians. Sounds wonderful, doesn't it? To have a system here in Canada where all the drugs are paid for and everybody had access to the necessary medicines that they require. But there is a price to that, of course, and you know that. And you mentioned some equitable revenue tools in your paper here, and of course, Mr. Oliver brought that up, the income tax, corporate taxes, and such. In your panel discussions, when you brought in some experts, did you talk about the costs involved and what you perhaps may, what the costs may be to implement what your recommendations are? Any specific numbers at all that you went through? And I would just like to know more about that, about the actual cost of implementing what you're recommending.
Sure. We looked at this largely in a comparative perspective as to what it costs to receive comparable coverage in other countries with universal health care. As you're well aware, there aren't any solid numbers in Canada because there hasn't been a determination as to what the right model is for Canada. And so the focus of our efforts was not to develop the fiscal model around this, but it was to at least gesture towards some revenue sources which the members of the panel felt would be productive.
Mm-hmm. You know, it's, again, I would love to drive the nicest cars on the streets, but there's a price for that. And likewise with universal Medicare system here, there is a cost, and people have to be cognizant of that, and I know that they are, but it just seemed that, you know, your panel was all about, you know, let's cover everyone, and I would love to see that as well, but there is a cost to it, and yeah.
Certainly the panelists were very sensitive to these costs, and to be clear, their intent was to cover everyone, but not to cover everything. And that's where the role of an evidence-based national formulary is essential to identify those medicines which are deemed to be both effective in health terms, but also cost-effective as well. Nevertheless, I think it was striking to realize that Canada continues to spend more as a country per capita to meet the pharmaceutical needs of its population than any other OECD country, barring the US and, as my colleague has pointed out, Switzerland.
Now, with respect to, did you talk a bit about perhaps the patient paying a fee for medication, have a portion of money that the patient would pay, rather than collecting the revenue through corporate income tax or income tax? Could you maybe just share a little bit of that?
So there's no question that many members of the panel thought that it would be advantageous to look at a system of co-payments, and that was really a values-based gesture, believing that everyone who can ought to contribute more directly to the cost of their care. Nevertheless, the panel hesitated to make that a clear recommendation because they were unsure of the potential consequences for low-income individuals and whether those co-payments, even as low as $1 or $2, could constitute a barrier, and then you'd have people not taking their medicines and being a greater cost to the system.
Mm-hmm. Very quickly to Ms. James, you talk about the behavior of Canadians and active lives and no smoking and healthy food choices. For these individuals who do this, should they be rewarded in some way, perhaps through tax breaks? Any thoughts on that at all?
I think Canadians who do that are rewarded with good health already, and that in itself is the reward. I do think that and Heart and Stroke believes that there are culprits that lead to poor population health, tobacco, sugary drinks, processed food, and it may be worth increasing the price of those options to fund for healthcare coverage and universal pharmacare. So that would be a good way to offset the difference, taxing the culprit as opposed to the individual.
Time's up. Good question. Mr. Ayoub.
Thank you, Mr. Chair.
In French, I'll be asking my question in French. On parle beaucoup de coûts.
There's been a lot of talk about cost and effectiveness. Unfortunately, in an ideal world, we wouldn't need to talk about savings. There would be easy choices. But I will address my question to the volunteer group, which deserves our congratulations for the work that you spent on this study. Universal coverage and its cost efficiency, the choice of a list of medications, and then a combination of private and public coverage. All of that really sums up the fact that there's a choice. We need to draw a line between what is acceptable for a majority of Canadians and what is exceptional for another majority of Canadians. So where do we draw this line? Are you ready to draw a line? You don't suggest one in particular because your recommendations are quite broad. This list should offer flexibility to take into account the individual circumstances of patients and ensure that the health system is focused on patients. It shouldn't include all. It should include all medications, including catastrophic medications. So you're not making a choice. That's not your objective. But the fact remains that a government. Well, what do you see the role of government? How do you see the role of government in this implementation and the ultimate responsibility of the economic cost and the health costs overall? Perhaps Mr. McLeod first.
Invite Jean-Pierre to speak if I
could,
and then I'll speak second.
That's a very interesting question for the simple reason that what I observed during those 5 days is that there is an imbalance from one province to another. There is no uniformity. We are aware that people with low income or income supplements and people and elderly people, what I concluded in my presentation is that people from 55 to 65 are the most vulnerable, those who don't have group insurance, who lose their work. And in my own environment, I know 3 couples around my age. I'm 63, and it's so sad to see that all of the money that they set aside, they had to use all of the money they set aside to pay for medications because they don't have insurance. I'm just one person, and I've observed this. I know 3 couples that are in this position. So if you spread that across Canada, well, that's what worries me. It's sad to see people who have worked their entire lives, and when they get to their retirement, they think that they have what they need to live, and they have a disease and they can't control it. There are activities to control disease, but I believe that there's work to be done. If there is a will, we'll find the way of doing it. Do we need to broaden the base of coverage for most chronic diseases or diseases that are more common among Canadians versus diseases that are more specific, less common, but which cost, well, because the fewer patients affected, the greater the cost of the medication. It's a mathematical issue. When you draw comparisons, Canada with 36 million people and the U.S. has over 300 million, the market is so different. How do you address this? What is your solution, Mr. MacLeod?
You know, the 2 ends of the spectrum really were of central concern to the panel. To provide those necessary medicines through a basic list in the first instance that would deal with many of those chronic and pervasive conditions, and relieve the pressure on Canadians who lack sufficient coverage. But also, and I think it's the reason why many provinces have moved to provide some degree of catastrophic coverage, they also think that there needs to be, as quickly as possible, action taken to absorb those costs to relieve Canadians of the burden that come with rare disease.
I think my time is up.
Time is up.
Thank you very much.
That completes our 5-minute round. Now, Mr. Davies.
Thank you, Mr. Chair. Mr. MacLeod, I want to refer again to your report where you say a national pharmacare system should provide coverage for drugs on a comprehensive, evidence-based, complete list. Medicines should be selected for this list based on medical and cost effectiveness. New drugs will be evaluated using the same criteria before they are added to the formulary. In order to be patient-centered, this list should be ample enough that it provides sufficient flexibility to take into account individual patient circumstances. This list will include the drugs proven to be most suitable for all conditions, including rare and catastrophic diseases. You go on to say this national pharmacare system should be provided through public insurance. And finally, however, all essential medically necessary drugs will be covered for Canadians under the public system. You have further said, though, that there is room for some private coverage to purchase optional private drug insurance. I'm interested in finding out what kind of drugs would be covered under the private system given the results of the panel's report.
There are, of course, many different pharmaceuticals available depending on the condition. And sometimes it's the difference between a generic and a brand name medicine. And I think it's the intention of the panel to move the generic medicines into a public system and perhaps not retain, not exclusively, but that you would offer a degree of patient choice around some of these brand names through private insurance.
Do I have it right, though, that the basic thrust of the panel's report is that all medically necessary prescriptions that are evidence-based should be covered under the public system? If someone wants to purchase a brand name over and above a generic or some sort of form of experimental medication, they're free to do so. But the goal here is to make sure that every Canadian has access to medically necessary prescriptions under the public system. Do I have that right?
That's exactly right.
And you probably heard from my colleagues in the Conservative Party, there's a little bit of a philosophical divide on this committee in terms of expense. What I'm hearing your panel suggest is very similar to the Medicare system, which sometimes I think I'm being transported back to 1962, where people are arguing it's too expensive to cover every Canadian for basic medical coverage. Sure, it would be nice to have everybody be able to go to a doctor or a hospital and get the coverage they want, but we just can't afford it. Of course, I think right now Medicare is one of the most cherished values of Canadians today, and not many Canadians would argue that we should dismantle our public healthcare system. In terms of pharmacare, am I right in just seeing this as a natural extension, the next stage of pharmacare to gradually expand universal coverage to the medicines Canadians need?
I believe so. I mean, the fact that Canada is an outlier in this area has to be of some significance. Other countries wouldn't have adopted universal public coverage if the health outcomes were lower and if the costs were higher. Canada, being a highly decentralized country with health responsibilities, of course, resting with the provinces, perhaps made it more difficult and has diffused responsibility amongst governments for seizing the initiative on this file.
My time's up. Sorry, that was a short round. Well, that completes our opportunity to have your testimony, and we want to thank you all for coming and providing a new perspective for us to consider. And if you have anything you can leave with us, we'd like to have it. We have the report of Mr. McLeod's report, but if anybody, either of the other witnesses have things you can leave, we'd like to have them. But again, I want to thank you very much for coming and providing testimony. We're going to take a 5-minute break, then we're going to go into committee business in camera. 5 minutes.
Thank you.